In Lecture 3, I'm going to be discussing some of the nursing interventions or the nursing care for patients with elimination problems, whether they be urinary or bowel elimination issues. Hydration is one of the things that we need to keep an eye on. They usually recommend 6 to 8 cups of water a day to maintain hydration unless it's contraindicated because of a chronic disease or illness. With hydration, what hydration does for an individual is it helps with making the stools softer, and then it helps to improve urinary elimination as well, and to make sure that we're not dehydrated, because if we don't have enough fluid, we're not going to eliminate the appropriate amount of urine that we need to. Typical amount that we want to see is at least 30 milliliters an hour when we're looking at urinary output on an individual. Also with hydration, when we're talking about water itself, we want to make sure that in the environment that we live in, that we avoid contaminated water, things that have parasites and bacteria, and you're going to find that this stuff the information is in your book, okay? From a health promotion standpoint, we need to make sure that we do encourage adequate hydration. We also need to ensure that we have adequate dietary fiber. Dietary fiber prevents you from becoming constipated. Okay, along with the fiber, we need to have adequate fluid intake. And typically, the amount of fiber that's recommended is 14 grams per 1,000 kilocalories of intake. And we have to maintain that so that we can have regular bowel movements and have a regular routine that we do. Regular toileting practices. As you get a little bit, older, you'll recognize, especially in the older population, where they have regular toileting practices and they go to the bathroom, they have a bowel movement every morning, and when they don't, then they tend to get concerned. So we need to try to help and assist our patients to maintain a regular toileting practice, working with them to ensure that they have consistent times for having a bowel movement. And that's one of the things that in assessment class you probably learned, is you have to assess for those bowel habits and routines, because it's very important to your patients. We have to instruct, or from a health promotion standpoint, work with our patients to teach them about the foods that can cause discomfort during digestion and absorption. And most individuals typically know what kind of foods will cause them problems as well. Regular exercise, when you look at, kind of flipping back just a little bit, this is in your book, it talks about things to promote health, promote urinary health. We have, and I'm going to go back and read over some of the ones I've already talked about, but we need to encourage adequate hydration. We need to empty the bladder at the first urge, not to wait. We need to work on maintaining a normal BMI, and this is going to fall and go along with some of the things in nutrition. So you're going to see where a lot of these concepts integrate with one another. Refrain from smoking, because that can inhibit. Smoking does a lot to our tissues and vessels and can cause damage in places that we don't really recognize that it causes damage. Omit or limit caffeinated beverages. They cause you to have to go to the bathroom more often, and then having a consistent exercise program as well. Okay, all these things go hand in hand with helping us to have normal urinary and normal bowel habits. Some other things that we need to make sure from a urinary retention standpoint, and to help us with prevention of incontinence, is that we need to have timely and complete emptying of the bladder. And what happens when we hold in urine is that this can encourage bacterial growth, which can lead to a urinary tract infection. Secondary prevention goes along with our types of screenings that we have. Colonoscopies need to begin at age 50 and go to age 75. Colonoscopies, when they prep the patient, we give them instructions the night before. They have to go on clear liquids and fast, and sometimes they'll do enema still clear, or they will do something called half lightly that helps them to eliminate the bowel and clean the bowel out completely, so that they can actually go in with a scope through the rectum and visualize the large intestines, okay, to see whether there is potential for cancer there, or polyps or other types of disease processes that could be seen. Occult blood screening we've already talked about a couple times. This is the Guaiac stool. These need to be done annually, plus they need to have a digital rectal examination to assess for prostate enlargement. So especially when they reach the age of 50 on men. So other things that when as far as secondary prevention, individuals need to be taught that bleeding, a change in bowel habits, there could be a tumor present, there could be something going on, so they need to have that evaluated. Okay. Patients at risk for colonoscopies, and some of these examinations are those that have advanced age, severe pulmonary disease, bleeding disorders, or prior allergic reaction to sedation. So these would be things that we would need to assess for. And having a colonoscopy, some of them may have some anxieties and fear and be embarrassed about the whole entire situation. So be aware of those questions that you need to ask. Collaborative interventions as far as treatment strategies will depend on the underlying condition. In this section, I'm not teaching you all of the disease processes, okay? You're going to get some of that as you go along. You're going to see where some of these disease processes are brought up in lectures and classes, and you're going to see them when you're on the floors taking care of patients. So the most common strategies that you're going to see is pharmacological or pharmacotherapy, incontinence management, and then you have invasive procedures and surgeries. When we look from a health promotion standpoint, patient education is key, okay? Promoting normal micturition or urination is also something that's very important. And then maintaining adequate fluid intake, which I've already kind of discussed a little bit already. We need to promote complete bladder emptying. So if you have a patient, that complains sometimes that they feel like they don't have complete bladder emptying, maybe have them sit there for a little bit, tell them to, practice some muscular exercises, which is something that we teach them Kegel exercises to improve the muscle strength, and we need to talk about how to prevent infection. So in women, we know from wiping from front to back, making sure that they have adequate fluid intake, different things like that, good personal hygiene. So there's lots of different things. The pharmacotherapy, as far as bowel eliminations, when we're looking at the pharmacy or the medications that patients can take, laxatives is something that we can give. There's different times they can be prescribed or they can be over the counter, such as bulk forming agents, bowel stimulants, lubricants, and saline laxatives. You're going to see things like called Miralax, Correctol, X-Lax. Correctol is one of those. It's a bowel stimulant that causes increased peristalsis. So there's different kinds. The thing that we need to caution our patients on is to beware that bowel laxatives can cause a patient to become dependent, and then those laxatives will decrease the impulse for them to defecate eventually. So they basically will do the reverse of what they're wanting it to do. Stool softeners is something patients are put on. You'll see Ducocet and things like that after surgery or when they're on prenatal vitamins, because a lot of the vitamins can cause constipation. But typically after surgery, we don't want patients to strain, so they'll be put on a stool softener. Not only during surgery, some patients are on them all the time so that they can maintain soft, easy to pass stool. Antibiotics will be prescribed for patients that have urinary tract infections or kidney infections, and they're based off the provider judgment or the results from a culture and sensitivity, or what we like to call as CNS. Urinary treatments, usually the medications that they're going to use is trimethoprim or tribethaprim with sulfa, or nitrofurantoin is the one that's most commonly prescribed for patients with urinary tract infection, and the other name for that one is macrodantin. Sometimes your severe infections are going to need IV antibiotics, especially for those with chronic pyelonephritis or kidney infection. And at times people will be put on prophylactic antibiotics for prevention of urinary tract infections, where they might take a nitrofurantoin once a day as a prophylactic, especially if they are prone to chronic infections or they have a suprapubic tube or an indwelling catheter. Diuretics are used sometimes to help us to pull fluid off of an individual. So it's going to create and cause the fluid volume to increase, along with excreting electrolytes such as sodium and potassium, which affect the water reabsorption. You're going to learn more about that when you learn about fluid and electrolytes. Anticholinergics is another type of medication that is used as an antispasmodic. It's used to relieve smooth muscle spasms in the bowel or bladder, and it decreases bladder spasms and provides relief from bladder spasms. Things like baclofen, I'm trying to think, those are the main ones. Sometimes B&O suppositories, which is kind of an opioid type suppository to help reduce bladder spasms after surgery. Imodium or I can't even say it. Loperamide is a treatment for diarrhea, and so it decreases that peristalsis, which helps to eliminate or reduce the diarrhea. I'm going to skip over this slide because I've already kind of talked about it already. Incontinence management is key when it comes to bladder and bowel retraining. Biofeedback is something else that we can use. So when we talk about bladder and bowel retraining, we're talking about regular toileting schedules, managing fluid intake, not giving people fluids right before they go to bed, maybe limiting it to maybe 5 o'clock in the afternoon or 6 o'clock, 6:30 as their last fluid intake. Also helping to modify the environment. Maybe they can't get to the bathroom. Sometimes they have to alter it. They need railings put on the wall to assist them with ambulation, whatever it is that's needed. Also, when somebody is incontinent, we need to make sure that we provide high-quality skin care and assessment of their skin, and then avoid medications that contribute to incontinence, such as Lasix, or other diuretics. Personal absorbent pads and bed protectant pads are important to have on the bed, and as well as, from a personal standpoint, if they have some mild incontinence, to be able to absorb the urine and not have that odor where other people can feel it. Biofeedback is where sensors are placed over the muscles to help with elimination, so they can receive feedback regarding muscles. So basically, it's trying to retrain the muscles. And then individuals with dementia, we need to take extra special care with these individuals to assist them with timed voiding and promoting and prompted voiding. Okay, to try to get them and take them to the bathroom every couple of hours. Okay. Colectomy, colostomy, ileostomy, we talked a little bit about this in the lab. I'm going to talk just briefly, and we're probably going to go into more discussion when we get into the lab. But we could have bowel elimination surgeries, such as a colonectomy or colon resection, you'll hear us say. And this is where they actually dissect a portion of the bowel. It could be because of cancer, diverticulitis, adhesions, things like that. Colostomy or ileostomy is a diversion, and you have a worksheet that you're working on that explains exactly what those are, and we'll go into that with some exercises in class. Rectal prolapse is when the rectum basically prolapses and where the stool can't come out, so they have to go in and surgically repair. And then you have your hemorrhoidectomy, which is required if the topical treatments for hemorrhoids are not working effectively, where they'll actually go in and cut out the hemorrhoids. Okay. Surgical interventions and urinary elimination. I mentioned this a little bit in the lab, but with prostate surgery, you can have TURPs, which are transurethral resection of the prostate, where they go in and they kind of rotor-rooter that area to open it up. Patients typically will have a catheter during hospitalization and may even go home with one until they're completely healed. Prostatectomy is typically used for individuals with prostate cancer. Urinary diversions I spoke about, where they actually either have to remove the bladder, and you would have an ileoconduit, or you could have a suprapubic tube. Surgery for renal calculi or kidney stones could be where they actually go in and remove that, or they could do a lithotripsy. And you can do some more reading about this in your book and look up more information if you're not quite understanding everything I'm saying. Stents to relieve obstruction. If you have a blockage to the renal artery or one of those areas, then they might have to go in and put a stent, and it's kind of like a straw that they go in and they open it up so that the blood flow can go to that area. Dialysis, things like that. Dialysis is when you get more into actual kidney failure, and you'll talk more about that when you get into further concepts later on. Okay. Just to briefly go over this, the interrelated concepts. I want you to be thinking about this as when we get into class, and because we've already gone over mobility and nutrition and those huge links that mobility and nutrition have to elimination. Not only that, but your cognition and in your fluid and electrolyte balance, and then your acid base. Those are some concepts that you're going to learn a little bit later on in the program. This concludes my lecture. Have a good day.